So the webinar is going to be recorded and then later on is going to be placed in the website that we have for the project. So today we are having the webinar about COVID-19 vaccine hesitance and digital and maternal and child health. So basically how this webinar took place, Melissa and me, we are co-leading this UK South Africa network around community-based co-design for maternal and child health. So we have been talking every month at least on different topics regarding maternal and child health. So this week or this month we have this especially on COVID hesitance, right? So the first thing I'm going to do, we have two nice panelists. The first one is going to be Zaynab Essack. So while I'm introducing Zaynab, maybe Zaynab can share her screen. I'm just going to stop my screen and you can share your screen, Zaynab. So Zaynab, she has a PhD in research psychologist. She's a senior research specialist at the Center for Community-Based Research at the Human Science Research Council. Zaynab's current research interests include sexual and reproductive health and well-being, especially for population at risk. She has been working with adolescents, with young women, developing and evaluating different sort of interventions to address different social issues, especially in high poverty. She has been also working with looking into the HIV prevalence in these communities. She has a developing interest in alternative R-based methodologies and engaging with adolescents in research. Basically, she will be presenting some of the findings of the different projects she has in South Africa around vaccine misinformation. So Zaynab, you can start now.
Thank you so much. Good afternoon, everyone. Can you all see my screen? Perfect. Thanks for the thumbs up there, Naval. So thank you for the introduction. I'm Zaynab Essack and I work at the Center for Community-Based Research, which is a part of the Human Sciences Research Council, and we are at a semi-rural site called Sweetwaters in the KwaZulu-Natal Midlands in South Africa. The data I'm presenting to you this afternoon is based on a 4-case study approach, which we conducted a couple months ago. So I was just saying earlier to Dr. Wong that it feels like some of these things are evolving so quickly, but this was the data we collected in April this year from Sweetwaters. This is just a description of our team. I led the site at Sweetwaters together with Dr. Groenewald, and we had a mixed method study. So we had members of the qualitative team and quantitative team listed here. And our PIs were Dr. Pillay, Dr. Coulson from Sarunia Health, and Professor van Rooyen from the HSRC, and Professor Charles from the SAMRC. We've also done work with Leicester University that's based on urban populations in KwaZulu-Natal, and where possible, I will make links to that work as well. So just some background on the community context, which for this particular work becomes critical in understanding vaccine acceptance and hesitancy. So as I mentioned earlier, we are a semi-rural site. A lot of the work we've done has focused on HIV treatment and ensuring access to treatment for community members in this context. We have a high rate of unemployment, a high level of poverty, and as I mentioned, a high HIV prevalence. It's a fairly small community, although it's widely spread out in terms of geography. We have about 20,000 people in this community. Just slightly more than half are female and 48% are male. 35% are young people below 18. The majority are adults under 64, so 18 to 64-year-olds, and we have a small older persons population in Sweetwaters. I'm sure you are all very familiar with this, but what we've often struggled with as a team within this work and the study is how do we define hesitancy? Because it's often defined differently by different organizations. And just for coherence in this presentation, I will use the WHO definition, which looks at hesitancy as the acceptance or refusal of vaccination despite the availability of vaccine services. And we can see on this continuum, there are people who will accept all vaccines, and then there are those who refuse vaccines. And I think of interest for this study was the group in the middle who were unsure about whether they would take up the vaccine or not. So the uncertain group. In terms of our methodology, we used a mixed methods approach. We reached out to key community stakeholders and did 10 key informant interviews. Then we reached out to further members of the community and did what we call expression sessions, which are participatory focus group discussions where we asked people to come with something that represented their experiences of COVID-19, and we got varied responses. None of them really linked to hesitancy, but it was about the impact of COVID. And then we had 4 very specific focus group discussions on vaccine acceptance, and we then ran a survey that collected data from 301 participants. So I'll start with the quantitative findings because I think a lot of the meat and nuance comes from the qualitative findings. As you can see from this, at the time we collected the data, the survey data was probably June, July this year. 15.5% of our participants had already vaccinated, and these were mostly older people and healthcare workers who were the priority populations at that time. We had about 10% who said they definitely would not vaccinate, and then 53.5% who said they definitely will. And then in terms of the unsure people, we had about 3% who said they probably won't, about 11% who said they were uncertain, and then just over 7% who said they probably will. And I think for all of us, we are aware that this uncertain group, and even the definitely yes group, that intention does not always translate to uptake. So we still need to be doing stuff to ensure actual uptake of vaccination at that point. But just in terms of demographics, so when we put all those, we accumulate all those percentages, we get about 22.3% who were uncertain about the vaccine. Most of them were younger, and I think this is typical of most cases where younger people tend to be more hesitant. It's generally typical of the South African population. We found interesting in our study that more women appeared hesitant than men, and that by school education, 70% who were hesitant had secondary school education, and 18% had tertiary education, and 11% had lower schooling. And now just to report on some of the detail that came up through our qualitative research, I'll present this as barriers and enablers for vaccine uptake. The 4 key themes that came up for us were literacy, trust, logistical and practical issues, and autonomy. I just need to, close this screen so I can see that. So in terms of barriers, we noticed that for our community, and this might be applicable across communities, there was very little accessible, trustworthy information. And when this information was available, it often was not in the local language that people could understand. Participants described that the language used is often scientifically complex, and they expressed concern about the pace at which vaccines were developed. Many spoke about the social media misinfodemic, where information was shared that was incorrect. And one participant here is quoted as talking about the many disturbing things shared on social media. Also linked to that is the amount of myths and misconceptions that are perpetuated either through social media or tools like WhatsApp, and the idea that the vaccine is here to kill people. So many participants, and in our community, there's not much access to technology in terms of cell phones. So within this context, many people described having received or seen some of this anti-vax messaging, and many described that they were worried about the safety of the vaccine and whether it would actually work. In terms of their thoughts on what would facilitate uptake, many spoke about the need for education that includes accurate information, including about the side effects. And I just want to read this quote to you about an analogy used with drinking water and the fact that people felt there was not enough information on side effects. So a participant said, "You cannot tell me to drink this water so that I feel better. I would then be surprised if I become drunk after drinking the water because you did not tell me that I would be drunk." So basically, getting the vaccine and being told you would be better, but not being aware of the side effects that come with it was considered to be problematic by participants. Some of them also spoke about the need for more responsible media reporting. So many participants were able to articulate or describe complexities around vaccines in other countries because this is often hyped up in media, and they were raising concerns about that. They thought awareness campaigns were needed, but that these awareness campaigns needed to involve local community members and that they needed access to correct online information. In terms of mistrust, I think this was something that we found across the 4 case studies was just a general sense of mistrust of the health system, mistrust of government, and mistrust of information. So for some participants, they didn't trust the healthcare workers that were providing the vaccine. They didn't trust the government in terms of the rollout of the vaccine, especially as it related to some of those issues regarding corruption. And they didn't even trust the information that they were provided with. So one used an example of someone in the executive at government taking the vaccine on TV, but there were rumors that that was not the actual vaccine. And then I think underscoring all of this in this particularly under-resourced community was inequitable access to health services, which was only amplified by COVID and in terms of access to vaccines. They made some really interesting recommendations that they wanted their vaccine champions to be more evident and to come from their community. So they didn't want very peripheral people to advocate for vaccine uptake, but wanted their chiefs and izinduna to go around and talk about the value of getting vaccinated and for themselves to be vaccinated. And they wanted more transparency in decision making. The third theme related to logistical barriers, which I think is more problematic in a semi-rural context where everything is very far apart from each other. And transport became a major issue. And I was reading a newspaper article today which spoke about the fact that transport is a key barrier to uptake generally in South Africa because of the cost of taxi services. And this was something that came up frequently during our interviews. That venues were inaccessible, that online registration platforms were difficult because many of our participants do not have access to cell phones. And then something that was quite heartbreaking to hear was that many of our participants also couldn't afford to stand in the long queues because they needed to look for work. And so they had made suggestions of offering some kind of water or fruit while people wait for queues, especially for the elderly. And then the enablers were recommendations made to improve access. And I think importantly, getting community healthcare workers who can come support some of that online registration was important. And I think at the time where walk-ins were not allowed previously. And then finally, many of them spoke about just the pressure to vaccinate or not vaccinate and how that influences their decision. Many of our participants were accepting of vaccines, but the few that were not expressed that they would outright refuse to take a vaccine and that they would want a gun pointed at them to take a vaccine. In our other sample with more urban populations and with people who are more employed, I spoke to them about what would happen if their employer required them to get vaccinated. And still some people spoke about the fact that they could get access to a vaccine card on the black market and they would first produce that before they would be vaccinated. So for some, the barriers were not just about education, but required a lot more effort in that regard. And then in terms of enablers, our participants spoke about being self-protected. So they wanted to protect themselves from COVID firstly, and then they spoke more about family and community protection. And then for us, and I think which was surprising in our very traditional community, was the idea that vaccination should be an individual decision. So even for people who spoke about wanting to consult their families, they thought that ultimately the decision would lie with them. Although in other case study examples, we heard of husbands who refused for their wives to get vaccinated, but this was not something that came up at our site. So just by way of some concluding thoughts, in our community of Sweetwaters, the important challenges or barriers to vaccination were the literacy gaps. And it was really comforting to see the president start using dual or multiple languages in his speeches, because that was a key barrier identified by many of our participants, was just understanding what the president was saying. And then the pragmatic barriers regarding transportation and figuring out how we support people who cannot afford to get to vaccine centers to do that. And then how we are more explicit about side effects in a way that is clear, less complex, but honest. And then in thinking about how we shift the uncertain category to those who accept, our participants provided some local solutions, and they spoke about in Sweetwaters the value of local vaccine champions, the need for simple, understandable local languages for communication, and just the need for communication more broadly. I think we heard in another study that there was one post on COVID in the entire community, and just more transparency on the vaccine process. And that's it from me. Thank you for your time.
Thank you, Zaynab. Very interesting. If you have any questions for Zaynab related to the presentation and the study, you can just use the chat. While Sarah is sharing her screen, I will just introduce Sarah Gong. So Sarah is an associate professor in media and communication at the University of Leicester. She has been working for many years in health communication. She has been investigating the representation on risk and uncertainty, especially lay and professional perceptions of genetic risk in relation to vaping and smoking cessation and health literacy of Chinese migrant women in the NHS maternity care. She has been also looking into parenting culture, consumer culture, and advertising with a wider context, the risk society. She's going to talk about her research on vaccine hesitance, especially with Chinese immigrants in the UK. And recently, she has been funding also another project where she is working with Melissa, Zaynab, and Naveen from India, me, and any other different stakeholders. Yeah, I was lucky to meet Sarah a couple of years ago when I was in Leicester. So Sarah, you can start.
Okay, thank you, Neville, for that introduction. So hello, everyone. Really nice to be here to share with you the findings from our study, and this is actually the very first presentation from our study. So a bit of a disclaimer here. We have just finished collecting our empirical data in September, so everything is very fresh from our researchers' notes. We haven't had a chance to properly done analysis yet, so the findings I'm presenting here are really very preliminary. So just to move to the second slide. Oh, sorry. So this is a bit of a study. Sorry, can you see my screen by the way? Yeah, okay. So yeah, this is the sort of summary of our study. It is funded by UKI and HSRC, and we have two locations where we conducted our empirical study in Leicester and Manchester. So these are two sort of reasonable size cities in the UK where we have large Chinese communities. And we work with two organizations, Wine Society, which is the largest Chinese community organization in the UK. It's based in Manchester, hence one of our research location is in Manchester. And we also work with Center for Ethnic Health Research. This is a research center affiliate to University of Leicester. So we are going to work with them after we finished conducting data analysis. We're going to discuss with them how we might be able to adapt some of our materials to other ethnic minority groups, for example, South Asian groups and Black Caribbean groups. And then the design of the study is based on qualitative research with focus groups. And we also worked with a group of community members as our working group to advise us on the design of a set of communicative interventions based on the findings from our focus group research. So we have done 27 groups with 131 participants over the past few months. In September, we finished our focus groups, and now we're in the process of designing and developing our communicative interventions. So Zaynab has already sort of introduced this concept. I'm sure people are here today are all very familiar with the term vaccine hesitancy. So I'm not going to repeat it here. So we've seen a lot of hesitancy among the ethnic minority groups in in the UK in relation to COVID vaccines. So I have some data. So since the availability of the vaccines in the UK in December last year, we've seen a lot of hesitancy among the ethnic minority groups. So the UK data show that the Black and then Black British, that's one category, and the Chinese and other, that's another category, and the South Asian communities are the most vaccine hesitant. Now, in terms of the Chinese communities, the acceptance rate is really, really low. It varied between 52 to 57%, which is significantly lower than that of the general population, which was at 76% in December 2020. And a lot of published studies are based on a rapid sort of survey research. Obviously, we need this kind of research because we just need to know the patterns and the trends in acceptance, attitude towards vaccines. But there are very few studies which are based on qualitative and in-depth kind of research design. So our study sort of aims to fill in this gap, and it is the first study to experience the experience of the Chinese communities, including their vaccine acceptance and hesitancy. Now, the Chinese community is a rather large ethnic minority group in the UK. The population is around 400,000. So it's one of the largest ethnic minority groups in the UK, and is one of the fast growing groups as well. The aims of the study are quite simple. So the first step, we just wanted to understand the factors and the determinants of COVID-19 vaccine hesitancy within the Chinese communities, as well as some of the barriers and facilitators of vaccine uptake. So we did focus groups to understand these issues. And then based on focus group findings, we wanted to develop culturally appropriate communicative intervention with quite a few elements. So here we have training materials for community workers and community champions, vaccine information leaflets and animation, a short film, community radio program, a mobile phone app, and videos of interviews with 2 Chinese GPs. So those components are color-coded. As you can probably guess, the red ones are still outstanding, so still a lot to do. And the green ones, we have completed them. And the blue one was not planned, but we had the opportunity to conduct interviews with 2 Chinese GPs. So we took the opportunity and did those 2 films with them. And in the second sort of part, our work, the design of communicative interventions, was advised by our community working group. So every step of the way, we have a workshop with them, and they gave us advice on what kind of content they prefer to see, what kind of format, and what kind of production outputs they would prefer. So we had input from our community group while we designed these intervention components. So we sort of read.
I think we lost Sarah.
I think we lost Sarah. She's back.
Oh, she's back. Hi, Sarah. Can you share your screen again? Yeah, it's coming, it's coming. I think you're still mute, probably because we cannot hear you. Yeah.
Okay. Well, might be better for me to switch off my video. So
Yeah,
if that's
fine.
okay. Yeah, okay. So we read some of the available transcripts and read some notes from our focus groups, and we have identified some reasons for the vaccine hesitancy among the Chinese communities. There are a few reasons which are known, which have been identified from other communities as well. So there are worries about side effects. So people worried about having side effects, so they're not able to go to work or look after their children or older parents. And for older community members, they worried about burdening their adult children. There was also mention of social media misinformation. For example, the vaccines might cause fertility issues for young people, and that vaccines could also cause facial paralysis as well. There are, of course, more kind of realistic health risks, including blood clots associated with the AZ vaccine, and also myocarditis associated with the Pfizer vaccine. So these are the known reasons we have found from the Chinese communities, but we also have found some reasons that are more specific to the Chinese communities. So for example, some people have told us that they have existing health conditions. So they have diabetes or high blood pressure, but they think that these conditions will make them too weak to take the vaccines. So this is contrary to what the NHS has been telling people, that if you have these health conditions, you should go and get vaccine so you avoid having, developing serious health.
Probably some problems with the connection. Sarah, you're back. We can also share your presentation.
Sorry.
Yeah.
Hi, sorry, I'm back. Hi. Sorry, could you go back, please? If you could go to, yes, that's the one, please. Yeah, thank you. So we have some reasons, as I said, specific to the Chinese communities. Some people told us that the vaccines are unnatural and they prefer more natural remedies. So for example, in Chinese culture, we have this kind of medicine or food, you use food to nurture your health. So they prefer to have that kind of, sort of health, assurance rather than having vaccines. And then there are also people who are probably sort of arrived in the UK recently. They are more sort of new arrivals, then they're not very familiar with the NHS system and they didn't know even where to get the vaccine. So these are the people who are probably not very open to the idea of get the COVID vaccine. And we also have people telling us that they are, homebodies, they stay home all the time. They think that social distancing and PPE should provide enough protection so they don't need the vaccines. And then finally, there are concerns about travel rules between the UK and China, because the Chinese authority requires certain antibody test requirements. So if you have if you have had the vaccine, then you might have a positive kind of antibody result, and the government might require another additional test, which we call M protein test, which is another type of antibody test, to sort of certify that the antibody you got from your the result, positive result, is from the vaccine rather than from virus itself. So these are the reasons why the Chinese community is probably not very open to taking the vaccines. If you could move on to the next slide, please. And there are also reasons for vaccination. People want to return to work. They wanted to look after their children and older parents. And again, for the older generation, they don't want to become sick from the virus, so they burden their adult children again. And word of mouth is very important. If they heard that their friends and family have safely taken the vaccines, then they're probably more open to the idea of taking the vaccines. And many of them actually said that, taking the vaccine and restore this kind of normality is a good cause. This is almost like a collective goal. So they wanted to contribute to this cause. We've heard this, reason quite often from, people from different age groups. Another very interesting observation from our data is that for immigrants who have probably lived in the UK for a long time, and they're more likely to come from Hong Kong, they're more familiar with the British system, they have a strong trust of the government and of the Oxford University and the vaccines developed by those organizations. So they are more open to the idea of getting vaccinated. But we also have people from, mainland China. They have a sense of, they sort of express their distrust of the government, not because of the vaccine, just because that there isn't enough measures to control the virus. There isn't enough social distancing or, wearing mask kind of requirements. So they don't want to sort of trust this kind of government not having, strong enough measures to protect their citizens. So it's kind of different, aspect of distrust. And then for young people, they have expressed the wish to travel and return to, normal social life, and therefore they're more open to get vaccinated. Next slide, please. It's interesting. I think we are under the impression that the reasons for both getting vaccinated or refuse the vaccines, I think they are sort of underpinned by, vulnerability. I think the vulnerability comes from, on the one hand, that those group of people think they are from an ethnic minority group and they lack social connection and they rely on family support. It's almost like the family, and then they have to sort of just to kind of protect themselves, and then that's the outer world and the virus itself. So there's a sense of vulnerability as the migrant of a society, lacking social connection, lacking support from colleagues, from friends, and from work, for example. And also there is a sort of vulnerability deriving from their understanding and awareness of the NHS, which is the UK's National Health Service, which has limited medical resources. in the past year, there has been a lot of media coverage of this organization being overwhelmed by COVID cases, or the NHS is going to collapse. So they don't have enough confidence that this healthcare organization can provide enough sufficient care if they fall sick from COVID. So there seems to be a gap between patients and formal care. They don't think they can rely on the NHS, that the NHS sometimes is a little bit difficult to get into, especially you have to get past this sort of GP system. So there is probably a gap to be filled by auxiliary medical or even social care organizations such as traditional Chinese medicine doctors or Wine Society. Okay, thanks, Nerval. And these kind of social care organizations. And then their decisions to take the vaccine or not take the vaccine is also influenced by their home country. For example, what kind of media they consume from their home country. For example, mainland Chinese people would consume media from China, mainland China, whereas in Hong Kong, people might consume more mainstream media such as the BBC, YouTube, things like this. So there are other kind of two reasons that I mentioned before, so I won't repeat myself here. And then we also noticed this prominent cultural value of collectivism. So we talk about this kind of collective decision within family and also in society. So we mentioned that people think we should contribute to the cause, the good cause. So I should take the vaccine, but also within the family members support each other. And usually the decision to take the vaccine or not take the vaccine is based on a family decision. So we're talking about extended family rather than nuclear family. We're talking about multi-generational families living in the same household. So that kind of collectivism, I think, is also reflected in there. If we could just move to the next slide, just conscious of my time. So we have been designing our interventions, and we have met certain challenges. Also have to say that we've been working with a great team of master's students and PhD students. But the challenges we met are also, noticeable, as I wanted to highlight them here. So first of all, we think that people need this kind of very personalized information. One is because they have certain medical conditions. People tell us that I have this personal health condition. I want you to hear from my medical professional that if I have, let's say, diabetes, I'll be safe to take the vaccine. So they want a very tailor-made kind of assurance from medical professionals. And they want you to have regular Q&As with medical professionals directly, which is not really very possible to do. And then I think the kind of information needs, very diversified information needs, comes from our social kind of demographic kind of context as well. We have seen diversity in language, in age, in media consumption, and their social conditions. So for instance, before we start the project, we know that audience have different needs and they come from different backgrounds. They use their different kind of experiences, knowledge system to understand risks. So we have decided to use different media, for example, community radio to look after, let's say, elderly people who don't, use social media, and illiterate people as well. And social media we have planned in our intervention and apps as well. So these are the media choices we have decided to do even before we start the project. But while we're doing those media production, we realized that actually it's more complex than we thought. So for instance, at the beginning, we decided to just do one film, which we wanted to document a person's vaccination journey. But then during the focus group, we realized that people have from different age groups have very different concerns. So we decided in the end to do 3 films featuring a university student, a restaurant owner, middle-aged, and then a retired Chinese medicine doctor, because their considerations are very, very sort of different. And also in terms of language, we wanted to add subtitles in the films, but we have been told by our working group that we have 3 different languages, we have or dialects, we have Mandarin, Cantonese, and English. So which subtitles do you put in these films? Because people are comfortable with their first language. So there is a choice to make. But if we put 3 languages at the same time in the films, it will be way too messy. and also been told by younger people that they prefer bite-sized content. They prefer very short content, let's say short videos. They can't sort of stand long videos, let's say 20 minutes long videos with doctors. They're just getting very bored of this long videos. So those are the kind of information needs we need to cater to, and it's very difficult for us to do this within these projects. And finally, the COVID situation is fast developing. We were just discussing this before the presentation. We have new jabs. We have jab for people who probably weren't included in the trials, and jab for people who have recently had COVID. Is that safe for them to do? And also we have new variants, new adverse side effects. So how are we going to keep up with those new conditions and include them in our interventions? Yes, that's another challenge. So I think maybe we probably need to use more Q&As and direct kind of interactions with professionals. That's probably one way to address those issues, but probably it's very difficult to arrange as well. So a lot of challenges to think about. The final slide, if we could move down to slide 10. So this is the app we are designing as well. I know we have computer sciences experts in our audience today. I really wanted to hear your feedback. So what we try to do is to build this app and incorporate all those elements, underscored elements, into this app. And the purpose is to kind of make this app very easily downloadable by scanning that QR code. And we also wanted to have a built-in function to collect feedback from our community members. We want to send notifications out. We want to link the app to official websites. And finally, we want to make the app open access, including the app itself, the codes, the server and database. So hopefully these things are achievable. I have a video here, but I don't think I have time to play it. So if you have any feedback on our app design, that is greatly appreciated. So I think I'll stop here. Sorry, I probably have gone over time and I've dropped offline a couple of times as well.
Thank you, Sarah.
Okay, thank you.
If there is any question for Sarah, you can also use the chat. So maybe we can go back to Zaynab because there were a couple of questions that she already replied in the text, but maybe she can just reply now by talking. So Zaynab, I think the first question was from Melissa. Did anybody express hesitance specifically for pregnant women or have thoughts on vaccines for children?
I have responded and in the chat. I don't know if you want me to talk through the.
Yeah, you can just summarize so everybody can just hear your opinion on that.
So as I mentioned earlier, we've been doing this work in different groups, and in our more urban sample, the issue did come up strongly about concerns about future fertility. And then also regarding breastfeeding and mothers breastfeeding their children and what the impact would be. So it is something that was raised, yes.
And then you have a second question from Nidello. I think you also replied, right? So basically,
yes, I have.
Yeah, it was about mistrust around the healthcare system and the government. So what do you think about how we convince people against COVID vaccine hesitance? Yeah.
So just to summarize my response again, I was just saying it's very difficult to shift issues of mistrust, especially in the South African context where these are quite historical. But I think it is important, and what we get from participants is that they become aware of the absence of information on side effects more long term. And they start viewing this as secrecy rather than something that is just not available. So just to be upfront about what gaps are existing is important, but also to highlight to people that there might be long-term effects of COVID that we are not aware of, and that might be equally harmful as taking a vaccine. So just being open and upfront in communication.
Thank you, Zaynab. Is there any other questions? I have a question for Sarah. And I think there was something about the influence of the home country, right? Especially when you're traveling to a new country, you have probably people are moving with all these cultural background and different practices and stuff. It was this particular part of misinformation and consumption of media from their own countries, right? Do you have any ideas of how to deal with this? Because probably people will still consuming media from their own countries, right? Will that be addressed through the app, or do you have any other ideas to address this?
Well, our idea, I mean, it's obviously people consume the media, you know, whatever media they want to consume. We can't sort of monitor them and change their media consumption habits. What we are thinking about is obviously to kind of emphasize certain key information through Why in Society, which is the organization that they identify with. They probably have maybe not day-to-day, but at least very regular contact with the organization. If we could sort of circulate some information through Why into those people and let them know and flag up this the information, saying that you should probably look at certain official media or trustworthy information from authoritative sources. Maybe they will kind of, I think, listen to that. I think whining is almost like a, filter for them, if you like, because they're new in this UK society. If they been told by, their community organization that they identify with, that there are certain, media you probably should look at, I think probably that is helpful.
You're looking into community organizations only in the UK or also in China?
Only in the UK at the moment. Yeah, because this study, we want to start from just migrants or immigrants. Sorry, I probably should have said, because I didn't use immigrants in my presentation because I wanted to sort of distinguish again these two group of people. Immigrants are probably people who have spent a long time in the country, but then we have migrants who are probably students or people who are just coming here to work, and they probably intend to return to their home country at some point. But yes, they do have this transitional kind of period of time where they get used to this new country and the new health system as well.
Yeah, I have seen so many students using different apps from China rather than from the UK. There is a question from Melissa there. To what extent did the concerns about pregnancy, breastfeeding, and children emerge in your data?
Sorry, Nervo, can you say that again, please? Is that for me?
Yeah, there is a question from Melissa, probably same question as before for Zaynab. To what extent did the concerns about pregnancy, breastfeeding, and children emerge in your data from your study?
Yes, I can see this now. I think there were some mention of, pregnancy, breastfeeding, but mostly I think it's probably sort of about fertility. I think that's more kind of probably prominent in terms of, misinformation, disinformation being circulated online. I think this and also this facial paralysis are the two, misinformation claims that we heard from the Chinese community. So there were concerns, especially from female community members, that whether the vaccine would affect their fertility. But we've asked the Chinese GP to specifically address that question, which he did answer very, very nicely. So after we sort of did a film with the Chinese GP and showed it to our community working group, they all commented to say that the doctor's response was really satisfactory. They're really happy to see that, to hear that response. So I think that probably helped. So I guess, sorry, Melissa, didn't really answer the question about pregnancy and breastfeeding, but yes, I think fertility, is probably one of the main concerns from misinformation.
Yeah, and then there is a follow-up question, especially after Martin's comment that especially COVID apps or anything, any app related to COVID are not accepted in the App Store. Probably is in order to preserve the trustworthiness of those apps and information. Are you engaging with anybody from the Department of Health or in the development of your app? So how is that handling?
No, we are not yet. That's a really good comment, Martin. I was just trying to kind of reply to your message by typing. We have a RA, research assistant, working on the app. He's a MA student from informatics. I think he said he is trying to find a way to package the app. Maybe that's not the right word, to be able to sort of to make it publishable on Google, Google Play and App Store. But I don't think that's possible now, just reading your comments. So do you have any, I don't know, suggestion in terms of what to do then if we can't publish it on the official app stores?
Martin has his hand up.
Yeah, Martin is raising his hands. You can talk, Martin.
Yes, thank you. Yeah, unfortunately, and this is a global thing, it's not a South African thing. And it's for the obvious reasons, because you don't know who's publishing what. So they've put a blanket ban on everything unless it's properly curated. So I know in South Africa and probably a lot of other countries have already published COVID-related information in apps. I think there's a South African one already on there. However, and this is just an opinion, I don't think, and I push apps. I think apps are the way to go. But I think in this day and age, I don't think apps for this kind of engagement are really appropriate. I don't think people want to download apps or go to app stores. The big trend, and I see this a lot in other avenues, in commercial avenues, is through influencers, community influencers, who have either got podcasts or they've got chat rooms, or they got a mechanism to talk to their communities, and whether that's a bespoke community like a Chinese community or broader, they are the people that can make change. And I think those are the people that we should be targeting to provide people that are vaccine hesitant. I don't think anti-vaxxers, you're not going to convince them, but vaccine hesitant people, if they get the right answers, I think from their influences, you could probably influence them. Thanks.
Yeah, and I think that for me highlights some of Zaynab's findings, where like very interestingly, they didn't believe the videos of the kind of well-known public influencers, and they really wanted videos of people from within their own community, maybe speaking in their own language. I don't know, Zaynab, if you want to go into more depth about that, but thinking through, like, if that's the thing, like if every community needs an influencer from that community to record a video and share it, like number one, what does that take technically to make that happen, especially since we can't use apps unless we're using existing apps or like communities that don't have data, what do we do? But also, like Sarah, you're saying it's not possible for you to produce one video for every stakeholder, every demographic that needs a different kind of video, because often video production cost is high. So like if that's a solution, having kind of bespoke videos per community, how do we actually enact that? How can we actually make that happen?
Yeah, it is definitely a challenge. I mean, we within this project, so I forgot to say that our project is a rapid response project, so it only lasts for 6 months. We have limited time and limited resources to do this. So when we heard from our focus group participants that they have very distinct concerns, we decided to do at least 3 versions. Young people, and then middle-aged people, and a retiree. But then we know that we can't cover everything. While we were planning this, we said, well, shall we do one female and male and female? So we cover that gender kind of differences as well. So we try our best to cover as much as possible, but it's literally impossible to satisfy everybody's information need, I guess. But on the question of how to reach, the community, I think, Martin, you're absolutely right. I mean, we we plan to do radio programs with a community radio station, and they're very kind to sort of say that you can come back to do a number of programs with us. I guess probably we can invite probably health professionals to join us as well to make it more dialogical, to also kind of provide the opportunity for the Chinese community to ask questions from, get answers from health professionals as well. Another thing we're planning to do is that we are trying to engage with social media influencers, but this is the sort of the next project. We're going to kind of approach them and basically, I think, pay them to say that if you could promote our programs, that'll be very appreciated. So I think that's probably a new kind of type of impact activity. I've seen other colleagues doing this as well. So it's basically use social media influencers. So they will probably promote our materials in their own way, and we will link our website, if it's not an app, maybe our university website, with those materials, and link it to their social media accounts. And hopefully that could reach more people, especially the younger demographic. So I think there are different things we could try, but I agree with your comments. I think it's going to be quite difficult to reach everyone.
Yeah, I think we have that discussion also with Melissa and a couple of people before about also for maternal and child health, how difficult it is to create videos and how expensive it is, and whether how the community can actually participate and create their own videos is also a challenge, right? But probably the way moving forward. And community radio is actually, if you remember a couple of webinars ago, we have maternal mental health, and there was a community radio that it was actually working. I think Martin has raised the hand. You have another question or comment? We still have to.
Yeah, thanks. Just so there is some really cool technology out there around video that we're using for creating subtitles, which means that you can create one video, you post it up to a platform, it takes your text, the spoken text, and it turns it into subtitles of any number of languages. So if you do it in that way, it means you can address a whole multitude of populations with a whole multitude of language issues. The other thing I think, again, is if you're going to have professional health professionals on a platform, get a social influencer on that platform as well. Nobody believes the health professionals anymore. They believe the people in their community. You also can't pay those influencers. You have to convince them that this is the right way to do. There's that saying, even placebos have side effects. So, people of today see through the influencers that are promoting Coca-Cola and whatever. They have to believe that this is the right way to do it, unfortunately.
Yeah, that's right.
Again, this whole influence community, I know it's new for, in research, but it's been around for like the last 12 years. The whole of the gaming industry, which is worth hundreds of billions, is all around social influences. The whole way that marketing has changed these days is around social influences. I think it's a priority for national health, which I'm pushing in this country, to use social influences to get the message out, because that is the trend of today. We don't have to research it. The research has been done by the big companies of the world that's selling goods.
Yeah, I guess it also depends of the community you're working on, because at least in our project, we saw that Limpopo, at least in South Africa, the community has had to develop trust in the community health workers and the healthcare setting. So there is a strong link there. But there might be other communities where that connection is not that well connected, right? Is there any other comment before closing? Because it's already 2. Yeah, I can see the chat as well. Many people are commenting. If no, thank you so much, Sarah and Zaynab, for sharing your research and contributing to the discussion. We will share the announcement for the next webinar probably in the next couple of weeks, because we already finished the first round of co-design, where we are going to invite the local researchers to showcase what we have done in South Africa in the last couple of weeks. Thank you, everybody. I will stop the recording now.